This project is a special populations assignment on individuals with co-occurring disorders who are homeless. This presentation is done by Derek Malenczak and Kristen Curi for Rutgers University. Okay, so we are going to be talking about co-occurring disorders and the homeless population. The goal of this presentation is to present a broad overview of the different barriers experienced by this population. We will be talking a lot about people with co-occurring disorders, so we'll be using the acronym COD in a lot of cases, both in print and possibly in our narration to relate to this population. So just a word to the wise in terms of being able to understand everything. And the reason for the need for this type of presentation is because of the significant amount of the population having co-occurring disorders in the community and in the institutions from where they originate. Among sheltered individuals, one study reported that 86% of people had problems with alcohol and 60% with drugs. We've been seeing quoted various numbers in the different papers we've read. So these numbers kind of tend to vary due to, I think, the difficulties with the last bullet point there, outreaching people and getting very accurate historical guidelines. So I think that's one of the reasons for the variance in some of the numbers, but it's certainly consistently above 50% and above for the numbers when it comes to people that are homeless and those experience co-occurring disorders. So that is really some of the background that we wanted to relate to you in why this is an important topic and important population to be studying. We've outlined the table of contents for you for this presentation. So the way that we've decided to go about it is we're going to spend about the first half of our presentation discussing results from the literature review in a lot greater detail. As you're about to see, there were 4 essential components found in the literature review that was part of the required readings for preparation for this presentation, and it actually ended up being really helpful in framing out and organizing it. So what we will do is talk about each of the 4 essential components over those slides from 4 to 21 for helping people that are homeless and have COD. And for each of those components, we have additional studies that we'll be presenting. Following the conclusion of going through the lit review, we will spend several slides talking about public policy considerations, financial, regulatory, cultural considerations, summarizing each of those for a little bit. And then towards the end, we will finish off with our SAMHSA recommendations for this population, which dovetail well, actually, as you'll see, with the literature review components that were found to be essential in helping this population. So we'll present those along with our final recommendations. And references will be available in the last 3 to 4 slides for your perusal. Okay, so now we are going to get into the literature review. This is from Soon 2012, and it was a very helpful article to read in preparing for the presentation, and after doing so we decided to sort of use this as our guiding principle way to organize things. So the literature review looked at a number of studies over the years involving homeless individuals with co-occurring disorder and found 4 essential components for helping this population. So the first one is effective transition from institution to community and ensuring how to make that the most effective transition you can. Number 2, increasing resources to this population, and that is a twofold approach. One is improving their access to government entitlements, and number 2 is increasing access to viable permanent employment, and whether that's through services designed to help support the individual or any other means possible. There's definitely a detachment from this population with employment opportunities. Three, the third component is linking the individual to supportive housing services. And number four, engaging them in treatment. And we'll explore a number of different treatments that have been shown promising for this population. Some of them are things that we've discussed in a number of other opportunities throughout this course, and we won't spend as much time on those things like CBT and motivational interviewing. But we will spend a good amount of time talking about the specific interventions that are discussed when referring to the population that we may not have seen in some of the other readings over the course of the semester in this curriculum. Okay, so I'm now going to talk about component one, effective transition from institution to the community. And when thinking about institutions, that can mean various places. So it might relate to hospitals, foster care, prisons, residential programs, or even shelters. So when we think about transitioning people, oftentimes an institution will have been providing the person's basic needs for sometimes a long-term time frame. And in preparing the person to be discharged and move into the community and access different supports than they're used to, a comprehensive plan is required and accountability needs to be established in order to prevent responsibilities from falling through the cracks. We talk about in the psych rehab principles coordinated ongoing services, and this is where this is highlighted here. This idea that there's a lot of potential for things to drop off when handing off responsibility from an institution, social worker, or a caseworker that is planning for this person to leave, and the bridge to the person entering into some kind of community agency program or support system. If they are expressing ambivalence about this discharge and transition process, motivational interviewing is a skilled intervention that is highly recommended prior to discharge to kind of explore that ambivalence and really support the person's self-efficacy in helping them believe that they are capable of integrating into the community and accessing the supports that are needed. Engaging people early in their stays in these institutions has been found to be really helpful as well. Not just waiting until the person is told by, say, the psychiatrist at a psych hospital, you're ready for discharge, and then the social worker starts the plan. Really, you want to engage people very early into their stay in the institution to say, hey, you're not going to be here forever. You're going to be leaving at some point in the future, and it's really important we start the planning process now. The last bullet point there, number 4, providing critical time intervention. I am going to spend a couple of more minutes talking about, I have a few studies that discuss this. So first we have Susser 1997, and this article was good in describing what CTI is. So critical time intervention has a twofold approach. The first goal relates to strengthening community supports for the long term and really making a plan of transfer that's comprehensive, as well as being able to anticipate any discontinuities that may exist between the institution and the community support provider that the person might be going to. The second goal is in the short term supporting the person, and the term is emotional and practical support. So what is that person going to need today to get them to tomorrow, and really making sure that those needs are attended to. So the Susser study looked at 96 men entering community housing in New York that were labeled high risk due to recurrent homelessness. And also having a multitude of co-occurring disorders. They were discharged from a 1,000-bed shelter in New York. This was a randomized control trial, or RCT, where approximately half the group was randomized to receive the experimental condition, which was the critical time intervention. and the control group received treatment services as usual. Um, they were followed for a period of 18 months, and the primary variable that they were looking at was average number of homeless nights spent. The experimental group, the people that received the CTI intervention, spent a significantly less nights homeless compared to the control group, an average of 91 less nights homeless. An average of 30 nights homeless versus 91 for the control group. The majority of outcomes and improvements were shown in the first 9 months of the intervention. The second 9 months, in the second 9 months of the study, the groups actually did not differ very much. So that is a good overview of CTI, what the components of it are, and some of the outcomes related to a number of homeless nights spent. Kasprow and Rosenheck from 2007 did a study on CTI as well and confirmed similar housing outcomes in terms of it increasing the or decreasing the number of homeless nights spent. It also was found to decrease substance usage as well as psychiatric symptomology. The final article I'm going to look at before I turn this over to Kristen is related to increasing resources in the community. So again, related back to the 4 components for the Soon article, the first one really related to making sure that discharge is well planned. The second one is increasing the resources for this population. Nowatzki et al. Looked at this in their article, The Need to Apply for More Government Programs, where they had 343 adults that were homeless with substance abuse issues only. It's important to note for this study, they did not examine mental health variables here, but they were looking at New York City soup kitchens and people who were accessing those to find out what type of public entitlements those people received. And the reason why they were looking at Medicaid and food stamps is their historical being modestly easy to acquire these benefits due to the fact that you don't need housing in order to have Medicaid and food stamps. You can be homeless. And so what they found were the results were the low usage of these entitlements for the population when comparing them to people who were even basically minimally housed, or what they called unstably housed. And those were people that did not have permanent housing but were spending nights in temporary housing, whether that be crashing with friends, family, living in a group home. They even label supportive housing in here. I'm assuming that would be temporary supportive housing where like the person did not have their own lease on an apartment, in addition to jails and hospitals. So it really does highlight the importance and the role of housing on the ability to access these entitlement resources. Even though they're not required, even though housing isn't required, there does seem to be some foundational margin of safety and established security needed to kind of have a roof over your head, a permanent one, before people are seemingly able to kind of progress in a lot of cases to be able to apply for these benefits and maintain them.
Okay, so now we're going to talk a little bit about how linking the chronically homeless population with co-occurring disorders to employment is actually very beneficial and has shown to provide positive outcomes. This study was a comparative study of the LA Hope Project, which utilized a collaborative approach to enhance housing and employment outcomes among the chronically homeless with co-occurring disorders. A little bit of background regarding this. In 2003, the U.S. Department of Housing and Urban Development, along with several federal agencies, launched a campaign to find effective strategies for the homeless population, and they formulated the Ending Chronic Homelessness Through Employment and Housing Project. They found that supportive employment was an evidence-based practice for housed individuals with mental illness and that it was cost-effective. However, most supportive employment programs don't serve people with histories of homelessness and co-occurring disorders. Out of that came the Los Angeles Homeless Opportunity Providing Employment Program, which was a 5-year grant to provide permanent housing, support services, and employment assistance to the hard-to-serve chronically homeless population with mental illness, substance abuse issues, and poor medical health conditions. LA Hope involved 4 agencies, which is part of the collaboration. The first was the City of Los Angeles Community Development, which was responsible for the workforce development centers and employment case management. Second was the LA County Department of Mental Health Services. Fourth was the Housing Authority of Los Angeles, which provided rental assistance vouchers, and also included was the Veterans Affairs Administration, who applied it a medical social worker. So all participants for both the experimental group, which was the LA Hope group, were recruited from the AB 2304 program, which was a state-funded support program providing social services and housing assistance to the target population. The first group, the experimental group, the LA Hope clients were enrolled in one of 3 of 18 AB 2034 programs at local mental health centers. The comparison group being enrolled in the remaining 15 AB 2034 programs between July 2004 and May 2005. All participants had an Access 1 diagnosis, history of homelessness, and co-occurring substance use disorder. The study was rolled out in 3 steps. The first steps, the CDD case managers recruited participants from AB 2034 to participate in the LA Hope project. This group received greater assistance via housing support than the control group. The second portion of the study, the enrollees participated in the HACLA Shelter Plus Care Voucher Program to secure housing. Interesting to note here is that although the study showed that they were placed relatively quickly, they did provide interim housing, usually via hotels, while they were waiting for permanent placement. After participants were permanently housed, the third step was employment linkage, which case managers prepared participants for employment and connected them to workforce development centers. So the results of the study, the LA Hope, at the conclusion, 57% of the LA Hope participants were employed, 11 times more likely to have been employed, and 6 times more likely to have worked in a competitive job versus the control. They also had significantly higher housing outcomes versus the control group. Successes of this project were contributed to using a housing first approach, where the LA Hope participants were not required to be psychiatrically stabilized or substance abuse free, whereas the control group, many of their housing placements did require this. So the conclusion of the group is the structure and resources given to the LA Hope participants were utilized in such a way that provided more support and contributed to higher outcomes. It's interesting to note that the LA Hope program had additional funding to pay for training, work uniforms, pre-vocational assessments, whereas the other control group didn't have any of those intensive supports. And it's also the collaboration between the various agencies that contributed to the program's success. All right, so now we're going to talk a little bit about resource expansion with a focus on Medicaid enrollment. There was a study that we found by Tsai, Rosenhack, Colleen, and Artiga, which sought to analyze health coverage, health status, and health service among the chronically homeless with disabilities in 11 U.S. cities. The Affordable Care Act of 2010 actually was really crucial in the expansion of Medicaid for low-income adults, which is starting in 2014. However, in 2012, the Supreme Court decision to give the states the option to opt out of Medicaid expansion is actually a significant impact on this population. The states are actually looking at the impact on costs, potentials for cost assets as insuring people. Okay, the study examined health characteristics, health service usage, socio-demographic status of adults below the threshold in Medicaid expansion, and compared them to those enrolled in Medicaid, those who are uninsured or relying on local assistance or other insurances such as VA benefits. The sample was 725 homeless adults from the Help End Chronic Homelessness Initiative, which took place between 2004 to 2009. Most of the information was collected via self-report and surveys. Results of the study showed nearly 3/4 of chronically homeless adults below the threshold for expansion were not enrolled in Medicaid, including the 53% who were uninsured or relied on state aid. These individuals could all be potentially covered under comprehensive plans with the Medicaid expansion. It should be noted that this population requires targeted outreach efforts and assistance to get people enrolled, as many are distrustful of service systems and have obstacles related to literacy and lack of documentation. Medicaid expansion would also allow those on city or local insurances to be transitioned to Medicaid, potentially saving costs to the state. Results of the study show that chronically homeless adults who are uninsured reported fewer health problems, but broad range of physical and mental health issues, indicating a need for better health status in this group. Enrolling this population in Medicaid could improve access to treatment and preventative services, but it should be noted that the need for case management and care coordination is particularly relevant, as preventative care has the potential to not only increase health care outcomes, but save long-term health care costs.
Okay, so now I'm going to be talking about supportive housing and the importance of linking people with supportive housing in their community. And the method of doing this, or the model that would be preferred, is the housing first model. Though we do see a prevalence of treatment first models in the community as well that were established during the time of the continuum of care model, really. So the housing first model, the difference really between the two is housing first, developed by Sam Simbaris through his agency Pathways to Housing, is really based on the premise that housing is a right first and foremost and not a privilege. And so people should have housing, and then after that, should they elect to have treatment services and or gain sobriety, it is up to them. It really does lend itself well to self-determination. Whereas the treatment first model really does presuppose that you must want the treatment that they are offering you, and you must strive for abstinence, is much more focused on that than the housing first model. So there was a study done, an RCT, with 225 participants who were homeless, and they were randomized to experimental group, which was the housing first group and had no prerequisites for obtaining housing, versus the control group, the treatment first contingent, where they did say treatment was a prerequisite for housing. These two groups were assessed every 6 months for 2 years total with the various measurement instruments. What they found related to these is that consumer choice, there was a significant difference between the two groups, where the experimental group, the housing first group, reported more choice than control. And this should not be a surprise to the listeners, as we said, housing first really does lend itself to self-determination, and if people are not being forced into rehabilitation and treatment as a condition for housing, they should report more choice, right? Related to residential stability, the experimental group had significantly faster decreases in homelessness, and more time was spent in stable housing than the control group. There was no significant differences between the two groups when it came to substance usage, and the control group did use significantly more substance abuse treatment programs than the experimental group. Lastly, regarding psychiatric symptoms, there were no significant differences between the two groups.
Okay, so now to build on the integrated supported housing model, we actually found this study by Smelson et al. In 2016, so it's fairly recent, comparing the mission model with a permanent housing first model. So mission stands for maintaining independence and sobriety through systems integration. And in addition to providing permanent housing, they provide ancillary case management services as well. So this was a pilot program that offered 1 year of permanent housing and mission services to 107 individuals in Massachusetts. And it was combined with interventions that were delivered by a case manager and peer support specialist who on average had about 15 people per caseload. The structure of treatment was about 2.5 hours of individual group sessions a week for the first 10 months, and this was reduced during the last 2 months. The mission model is comprised of 5 crucial elements, the first being, as mentioned previously, critical time management. So, this is case management, which gives immediate housing placement and service linkage as soon as the clients enter into the program. Dual recovery therapy support, which is 13 sessions given in the first 3 months where the clients learn about mental illness, substance abuse disorder, and skill building. The third component is peer support delivery, delivered by a peer specialist with training in harm reduction and assertiveness skill building, and this was about 11 sessions. The fourth component was vocational and educational support. Both case manager and the peer specialist linked clients to services in their community to enhance goals and stability. The fifth component was trauma-informed interventions. The mission model in and of itself doesn't provide specific trauma services. However, they do refer their clients out to other settings if appropriate. The study closely monitored fidelity to the mission model via verification of usage of the treatment manual and the consumer workbook. The case managers and peers are all trained to deliver a housing first philosophy with immediate access to permanent housing without a requirement of psychiatric stabilization or sobriety. It also focuses on consumer choice, is recovery based, and is client driven. A little bit different from the housing first philosophy is mission does imply a fairly assertive outreach component to link clients to services. Although it still utilizes a harm reduction philosophy and client choice, they are a little more assertive in trying to get clients to utilize treatment than the housing first approach. This approach actually coordinating housing and support services they feel is really needs to be implemented to be maximally effective. So the results of the study were that 95.3% of participants were placed in permanent housing and 86% remained in mission and receiving treatment at the conclusion. Improvements were seen in mental health, recovery, and housing outcomes. However, there were less gains in sobriety. So strengths of the study include rapid housing placement, partially due to participants receiving all services from the same team, the case manager and the peer specialist. Although the study did find that there was less fidelity to the mission model in terms of the dual recovery therapy sessions early on, and they attributed that to clients preferring to focus on housing stabilization earlier in the program. Again, just to reiterate, mission model does differ from the housing first approach because they are more assertive in trying to get clients to utilize treatment services. So this study does prove that although the mission model and the housing first philosophy do differ somewhat, they can be compatible if implemented concurrently. Some limitations of the study was that there was no comparison group, no qualitative data collection, and the study team felt that a longer follow-up period would be needed to effectively measure outcomes. All right, so we're going to continue in the evaluation of housing stability outcomes using the housing first model. This study was a comparative study on the pathways model. Okay, so this was a comparative study that sought to look at the different outcomes versus 3 housing models that all implemented a housing first philosophy. The original Housing First model implemented by Pathways to Housing was compared to two other programs varying slightly in structure. And the study was conducted by Pearson, Montgomery, and Locke in 2009. And common features of all three programs are typical of Housing First models, which is direct, fairly quick placement in permanent housing, the offering of treatment services but not a requirement to participate, and assertive outreach to those with mental illness, and a harm reduction approach for substance use. And housing, key feature of all of these programs was that any temporary leave from the program, the participants' housing would be held for 90 days. So Pathways to Housing is based in New York City. It is the original Housing First model. In this study, the majority were referred straight from psychiatric hospitals, which was actually key in the outcome of the study. Other components included assertive community treatment support, and unique to Pathways was that the participants were given 3 apartment choices before they were permanently placed. The structure of the housing provided was that Pathways subletted leases to the participants through private landlords. The second model was the Downtown Emergency Service Center, which was based in Seattle. And most of their participants were referred by outreach workers. A majority were living on the street at the time of enrollment. And interesting to note is they were the only model in the study that had a wait list, which reserved spots for those with severe and persistent mental illness. DESC owns and operates about 4 buildings, which is different from Pathways and the REACH model, and the residents are given their own lease. The third model was REACH, which is based in San Diego, and majority of their clients were enrolled, were referred directly from the street and outreach workers. REACH does not own or operate any of its own units, and the study found that they had the least fidelity to the Housing First philosophy because many of their participants were enrolled in community housing where there were restrictions that clients needed to be psychiatrically stabilized or sober prior to being permanently housed. They found that residents in this model engaged in more problem behavior and had lower rates of satisfaction with their housing and were more likely to leave within the first 12 months. So the study found that the programs offering the greatest flexibility combined with permanent housing was Pathways, who had 96% at 12 months and with the lowest number of incidents. Individuals with the highest levels of housing stability were from Pathways. They came directly from hospitals or jails or other institutions versus the clients in the DESC and REACH program who came directly from the street. Key point made by this study is that temporary departures among the homelessness population from their permanent housing is common, and ongoing support of staff is a crucial stabilizing mechanism to keep clients engaged. Participants' reports of satisfaction related to independence, safety, and housing quality all were noted as key outcomes to the study as well. So while Housing First solves the problems of homelessness, they found in the study it doesn't resolve other issues like behavioral and substance use, which was still evident in the study as there were no significant changes in impairments related to mental health or substance abuse symptoms. All right, so now we're going to talk a little bit about contingency management. Contingency management techniques have been shown to be effective in working in the substance abuse treatment population, and the study found that homeless shelters are really prime locations, to provide these interventions. Given the nature, the transient nature, people really, frequently move from place to place. So, attempts to implement contingency management strategies with the chronically homeless have been difficult in the past, and they've also found that they've been costly to implement. So this study by Tracy et al. Conducted a 4-week low-cost randomized control study for 30 chronically homeless individuals with co-occurring disorders residing in a community shelter in Connecticut. And the experimental group, the study was divided evenly, 15 per group. The experimental group were given the contingency management techniques and combined with behavioral assessments versus the control group, which were assessment only. Behavioral assessments were performed at the beginning of the study, then weekly, then at conclusion. Overall, there were high retention rates in both groups, and those in the contingency management group reported alcohol and cocaine use over the reduced their alcohol and cocaine use over the assessment group, which was verified by urine drug screens and breathalyzer tests that were given twice weekly. In the contingency management group, attendance and abstinence was rewarded by a number of chances to pick prizes from a bowl. Most of these were gift certificates or small monetary rewards, $5 to $10. The number of chances was relative to the behavior. If any positive sample was given at any time, it was basically escalated. So if they reported a positive sample, the number of chances they had to pick was returned to that of week 1 until they could provide 2 consecutive clean samples. Overall, substance abuse was low in both groups. Contingency management was 96% at assessment. Contingency management was 96% versus 75% for the assessment-only group. And there's similar results for both cocaine and alcohol. This trial demonstrates the feasibility and effectiveness of a low-cost contingency management program is possible, and that intervention is a shelter is a prime location to implement with this population.
Okay, I'm going to talk a little bit about harm reduction and ACT. So harm reduction, we've discussed a little bit earlier when mentioning supported housing, and specifically Housing First, or Pathways to Housing, the Semberis program in New York City. It's an intervention used to limit the seriously adverse effects and risks related to substance abuse. And again, is very consistent with the psych rehab value of self-determination. So it works well with our philosophy and is one of the defining features of the Housing First model. The reason for that really is due to its pragmatic approach when considering the needs of the population and thinking about stages of change and stages of treatment. This idea that sometimes somebody is not in a real active stage when they enter into housing because they've been working to address so many other barriers, that's only after their life calms down a little and they do achieve some stability that they do become more motivated and empowered to address the co-occurring disorder in earnest. The usage during the engagement stage of treatment is particularly helpful because the person can still establish a therapeutic alliance with the person even while they might still be continuing to abuse substances. And the practitioner is just working to limit the most negative, impactful ones. It does rely on the fact that housing status is not affected by usage. You're not going to get quote-unquote penalized if you are found to be, not sober. The natural consequences still would remain, so that if the person was unable to manage their substance abuse issue and it caused them to lose their housing because their landlord could not work with them, that would be, still in effect. But always under the auspice that help is going to be available to people that ask for it. Just a quick note on ACT before we get into our next intervention. ACT is the primary model for providing treatment and rehabilitation services within the Housing First program. So they really do work assertively to go out there in the community and make sure people are, taking their medication as prescribed, staying safe in the community. So ACT goes well with harm reduction in sort of being practiced within the Housing First model.
Okay, so now we're going to take a little bit of a look at healthcare for homeless veterans, which is actually, kind of a subpopulation within the chronically homeless population. This study looked at the effectiveness of residential treatment for homeless female veterans over the course of 1 year. Currently, the Department of Veterans Affairs has 11 specialty programs for homeless female veterans, and they estimate that 4% of homeless women are veterans, who, like many homeless people, experience high rates of mental illness, substance abuse, and trauma. Homeless female vets are 3 to 4 times more at risk for homelessness than non-vets. Several programs have been established by the Department of Veterans Affairs to identify homeless vets and link them with services in the community to expedite treatment, including community residential treatment, which is shown to reduce psychiatric and substance abuse symptoms and improve function. About half of the vets in the program receive community-based residential treatment. The study looks at women that were enrolled through the Homeless Women's Veterans Program, and participants were referred by their case managers. However, there was no actual assessment instruments used. It was basically if the case managers deemed their clients to be eligible, they referred them for participation in the study. For the experimental group, women had to be enrolled in residential treatment for at least 30 days versus the control that were not in residential treatment. So at baseline, the residential treatment group had lower incomes, were more likely to be Black, less likely to have minor children. They did have better mental functioning status, but more severe substance use symptoms. The conclusion of the study was that those in the experimental group, on average, had more days worked, higher social support, lower symptoms of post-traumatic stress disorder, better scores in mental health functioning, but on average had higher scores for drug and alcohol use. The data shows that placement in residential treatment for at least 30 days showed significant improvement in clinical symptoms, at least during the first year. The study contributes safe housing provided early in recovery is crucial, especially for those in histories of trauma, so that more time can be dedicated to recovery rather than on basic survival, such as looking for housing and or basic supports. There were several limitations of this study. The women were not randomized, and they also hypothesized that those who were willingly entered into residential treatment would be more willing to commit to sobriety while living in the program. However, another limitation of the study was the lack of longer-term follow-up.
There were 3 other treatment interventions that were discussed that we highlighted a few slides ago. I just wanted to mention motivational interviewing, cognitive behavioral therapy, and psychoeducation. So these are 3 interventions also shown to be effective for the population. We didn't want to spend too much time on them, though, as we have spent a good amount of time talking about those through other parts of the course thus far.
All right, so I'm going to talk a little bit about some current public policy issues that influence service delivery to our population. Right now, there is some pending legislation in Congress that would directly affect treatment for chronically homeless individuals with co-occurring disorders. The first of which is Senate Bill 2680, otherwise known as the Mental Health Reform Act of 2016, which is actually getting a lot of publicity, from various advocacy groups and other mental health and substance abuse agencies. To summarize the bill, it calls for combined federal efforts to end homelessness through interagency efforts, increase mental health service block grants with specific monies set aside for homeless treatment services. The bill also will call for a stricter monitoring of agencies, social service agencies reporting outcomes for their homeless services and ensuring that they are utilizing best practices in their care. The bill would also call for Health and Human Services to strictly enforce mental health and addiction treatment parity. And currently, Bill 2680, the current status is in April 2016. It was passed by the Health, Education, Labor, and Pensions Committee and is currently awaiting for further Senate consideration. The second bill that is currently in Congress in the House of Representatives is the Helping Families and Mental Health Crisis Act of 2016, which has some similar objectives to the Mental Health Reform Act. It does specifically call for the development of a severe and persistently severe mental illness committee that would create a federal plan to improve treatment outcomes, reduce homelessness, and increase employment. A key portion of this bill is that this committee would include an expert on homeless services. In addition to the Mental Health Reform Act, they would seek to expand mental health service block grants for mental health treatment, housing, and employment services for the chronically homeless population. And that bill actually has fully passed the House as of July 2016.
Okay, I'm going to talk about some financial considerations that influence service delivery. Certainly, we know that some of the most expensive services that are available in the community are often used by the homeless individuals experiencing co-occurring disorders. Places like emergency rooms, inpatient hospitals, also prisons, which is unfortunately a de facto involuntary patient place for many individuals that get picked up on the streets. In addition, screening services and emergency ambulance services are all extremely costly and really weigh on the budgets of different states providing services to needy individuals. So this is certainly a financial consideration that we do want to address, and supportive housing has been attempting to address by this idea of placing somebody in their house first and foremost, so as a way to avoid some of the more costly services. Related to CTI, which was the critical time intervention discussed earlier, there was a cost effectiveness study done, Jones et al. From 2003, which found that CTI did decrease the number of nights spent homeless, but not at a significant cost savings. And that sort of is echoed in the Rosenhack et al. Article related to cost effectiveness of supported housing. I've heard in practice over the years, how much the cost savings is, anecdotally versus say group homes. This study looked at homeless veterans that had a diagnosis of mental health, mental illness, and/or substance abuse disorders. So they didn't necessarily always have both. They found good outcomes. Supportive housing did result in better outcomes, but not at a cost savings compared to traditional case management services. And it was determined that the provision of supported housing services ended up costing an extra average of $45 per day to spend housed versus standard case management. Now we're going to talk a little bit about the regulatory processes that influence service delivery. For this, we really took a page out of New Jersey's book. The movement from a regulation standpoint has been one of integration between government programs that oversee mental health, substance abuse treatment services, as well as homeless services in addition. So the state of New Jersey, referencing the task force report from 2010, is an interesting, good model to look at, as their merger highlights both the benefits of integration as well as the regulatory barriers. Specifically for people experiencing homelessness with co-occurring disorders, they acknowledge the inadequacies that exist regarding coordination and planning among the many service providers, and the need for multiple stakeholders that represent the needs of these populations to come together, jointly fix the broken system. They also acknowledge the need for additional clinical skills to be developed that will meet the needs of these special populations. And when we think about them, we are not just thinking about homeless individuals, but also people in other special populations, them being women with children, adolescents, people with HIV, people in the criminal justice system. They sort of mirror, I think, some of the populations that other groups were asked to present on for this project. I'm not going to lie in the fact that we don't have a lot of concrete solutions to these regulatory hurdles. which have contributed to ineffective service delivery, but we are able to recognize them and can see some of the more prevalent barriers that exist.
All right, so now we're going to talk a little bit about some cultural considerations that impact service delivery. As we know, as behavioral health care workers, cultural competence is really a necessary component of care. So some statistics from SAMHSA, 59% of the sheltered homeless are minorities. And as of 2009, the number of substance abuse treatment admissions identifying as homeless were 29.9% African American, 15.8% Hispanic, 2.9% American Indian and Alaskan Native. It's also shown that African Americans with severe mental illness have a higher likelihood of homelessness and are less likely to seek mental health services. Whites with severe mental illness are more likely to be homeless than Latinos or Asian Americans. Also interesting to note, for individuals in cohabitating in the same shelter, African American women were less likely to receive antidepressants from their caretakers than white women. Although at this time, relationships between race and ethnicity are poorly understood. When providing services to the homeless, it's important to understand their unique culture with an inability to fit into the greater social system, and that many of their struggles, including mental illness and substance use, occur in isolation. It's also necessary to look at additional sociocultural factors that are evident in this population, such as lack of education and job prospects, and histories of domestic violence and trauma. Barrier to treatment that occurs frequently in this population is the tendency to avoid services, which is really need to be viewed as a form of self-protection and not just mistrust. People are kind of in survival mode, and they've learned to survive, a specific way. And as any other, unique culture or group, they all have unique survival strategies. And, this perspective really has to be, incorporated into services that are being provided, and has to fit with the present time orientation. Services that kind of are geared more towards the long term, or, employment that's going to take, a year, a training program for a year to get a job is probably not going to be a good fit for a lot of people that are coming out of chronic homelessness. Realistic objectives have to really be incorporated, and there is a real need, as social service workers to really, adjust our own attitudes and stereotypes regarding people, who are homeless.
Okay, so we're going to start to wrap up now. The SAMHSA has a tip 42, which discusses some recommendations and interventions for this subpopulation. Certainly they recommend, from the housing specific standpoint, the supportive housing, and highlight some of the outcomes beyond residential stability, them being they use less emergency services, average psych hospital stay decreased, and their cost to provide treatment decreased. They are also recommending integrated treatment within the shelters. They talk a little bit about the TC, or therapeutic community model, which is an alternate to supported housing, which does promote abstinence, does decrease antisocial behavior, and affect positive change. It's more of an intense mutual self-help community. They've proposed a modified therapeutic community where the major difference is in response to addressing psychiatric symptoms, and then more of a focus on conflict resolution within the therapeutic community. And overall, this has led to increased flexibility, decreased intensity of service, and increased individualization of services. So the consensus recommendations from SAMHSA for people with co-occurring disorders and are homeless are that they really need to address the needs and barriers to housing first and foremost, whether that be assisting individuals with obtaining housing, skill teaching in order to maintain housing, or coordinating with shelters and other providers related to discharge. And then the need to address issues related to housing stability, substance abuse, criminal justice, Social Security entitlements, child care, health care issues. It was interesting when reading these recommendations, if we return to the lit review for components and sort of compare the two, we see a lot of overlap. When we look at transition in the community, we look on the right side, that really does relate to addressing the needs and barriers of housing, assisting individuals with obtaining it, and coordination with shelters. When we look at increasing resources, we think of addressing issues related to housing stability. Um, Increasing the linkages to supportive housing is supported in the SAMHSA recommendation of assisting individuals with obtaining housing. And then finally, engaging in treatment. We really spend a lot of time focusing on the skill teaching aspect of it, but if we are unable to, from a psych rehab standpoint, skill teach, referring to other services, for instance, CBT, or some of the more specialized services. In addition, just some final recommendations. We recommend having a variety of interventions at your disposal. As it is such an individualized service, we really do need to have a multitude of interventions available depending on the person. We need to have a hypersensitivity of potential for failed linkages, coordination, and follow-up. So we need to be aware that this happens more often than not, and to be doubly aware and take the extra steps to make sure that these linkages are successful. As practitioners, we should expect relapse to occur and have a fundamental understanding of motivational interviewing, because we do use the stages of changes, or we should use it as an assessment tool for checking in on someone's vital signs. People's motivation and their stages change, day to day, minute to minute, and we as practitioners need to be able to adjust our interventions accordingly. So hope you guys enjoyed this presentation. Thanks.